Good afternoon. My name is Monique Green, and I am a physician assistant here at the Department of Pediatrics and Child Health at Howard University. I would like to introduce you to our last speaker of the evening before we open it up to question and answers and the patient panel. Our speaker will be Dr. Josephine Briggs. She is the director of the National Center for Complementary and Integrative Health at the National Institutes of Health. She has published more than 175 research articles, book chapters, and other scholarly publications, as well as served on editorial boards of several journals and serviced several leadership roles. She's also won numerous awards. Her research interests includes policy and ethical issues around clinical research. So would you please let us welcome Dr. Briggs?
Thank you very much, Monique. You'll help me find my preparation. So I was told to start by telling you that I, as a federal employee, have nothing to disclose and no conflicts of interest. But I do have a real thank you that I owe to the organizers to invite me to be part of this terrific symposium. I've been here for the last 2/3 or so, and I love the format. The great talks by Dr. Darbari and Wright have, I think, very well epitomized the kind of groundbreaking work that's so important in the pain field. But hearing two such empowered patients' own stories is really enriched this conversation enormously. So Portia Hall and Myrtle Williams, I really enjoyed your comments. And indeed, patient empowerment is an absolutely critical part of chronic pain management. So I'll tell you just a little bit about what we do at the National Center for Complementary and Integrative Health. Our name has recently changed. It used to be the National Center for Complementary and Alternative Medicine, but we have found that alternative medicine is actually not what most Americans are doing. The advance button doesn't seem to be working. Here we go. Alternative medicine refers to unproven practices used in place of conventional care. And we have learned over the last decade or so that most Americans use complementary health approaches as complements to conventional care. It is a group of diverse medical and healthcare practices, a number of which you've heard referred to already in this conversation, that developed outside of mainstream medicine, such as manual therapies, acupuncture, traditional Chinese medicine, yoga, tai chi, meditative forms, as well as herbal products. And integrative health care is the phrase being used as an interdisciplinary approach to treatment, prevention, and health promotion that brings conventional and complementary approaches together. So as Dr. Wright was talking to you about the evidence base, supporting the kind of research that will ensure that we have an evidence base that will support the kind of rigorous compilation of data that he described to you in the development of acute pain management. That's what our job is at the NIH, is to make sure that kind of thing is happening and to direct the research dollar to building that evidence base. And I like to talk about this man, David Satcher, because evidence-based medicine gets misquoted a lot. People think of it as being a kind of create a cookbook for medicine, but it really isn't intended that way. It is about a patient-centric approach that integrates the individual clinical problem with the external evidence. And that is a critical notion behind evidence-based medicine. So although it is sometimes perhaps misused, the correct interpretation does start with where the patient is at, with the patient's experience. And that's why the experiences of the two superb advocates you've heard today are central to thinking about evidence-based. So this is what David Satcher wrote. It says, by individual clinical expertise, we mean thoughtful identification, compassionate use of individual patients' predicaments, rights, and preferences. I love that phrase because I think that is what good clinicians aim for, is a starting point, what really matters to the patient. It's really tough to implement in pain management because the patient's predicaments are so intrusive into their everyday life, and helping patients move from the state of really being incredibly burdened with pain to a sense of empowerment, a sense that they have strategies to help. It is the critical role the healthcare system plays, but it does stay centered around the patient. Those are the three phrases that I think are central to this. Well, complementary health approaches are, in fact, used by physicians and all healthcare providers. They're not, although some skeptics think of this as things that no doc would use. In fact, the reality is physicians are also using complementary approaches, including supplements. These are the top dietary supplements used. None of them, frankly, are much help for chronic pain. So I'm going to leap ahead. I have a few slides on this, but the time is a little less late, and I'm going to leap ahead to the mind and body approaches. The top used right now by Americans are chiropractic and osteopathic manipulation, yoga, massage, and mindfulness meditation. And we have a growing body of evidence based probably partly on the kind of mechanisms Dr. Darbari showed you, that these treatments can really change central processing of pain. This is important work. I think it's work that's only at its early stages, as she correctly indicated, but we all know from our own personal experience and from talking with patients that the emotional state around pain can make it so much worse. And so context, expectation, fear is an incredibly powerful modulator of pain. And so can be the empowerment from feeling that you have approaches that can help, that go beyond drugs. Now, a couple of things I say may sound like I'm not wild about opioids. Opioids are problematic drugs for chronic musculoskeletal pain. They are wonderful drugs for somebody who just broke their leg. They are, in fact, incredibly helpful drugs for people living with the chronic pain at end of life. But they are nonetheless ones that, as chronic daily use, may in fact not help all that much over time. They help acutely, but do they help chronically? Well, it depends. So building strategies that will empower patients to have greater sense of control, and that they will have available to them a complement to drugs is incredibly important. So here's a nice example. This is a study of Tai Chi for fibromyalgia. Was performed by Gloria Ye, published in the New England Journal. And she randomized patients to either standard exercise stretching regimen or the ritualized meditative exercises that are Tai Chi, and found that the patients showed substantially more benefit in this reasonably small but very rigorously performed study that suggests, and we are now involved in supporting a larger replication study. But one of the reasons I think that Tai Chi was so helpful is that it was easier for people to do. It started with where the mental state of the patient and was one that could be incorporated into those are the papers, and we were pleased after that came out that Jane Brody in the New York Times said, "Is there a downside?" Well, none that I can see. And that is, of course, part of the reason these approaches are important, is they do seem incredibly safe. And so if they work for a patient, they will be empowering and as complements. Now, they're not replacing medication, that's absolutely clear, but they are moving to a patient-centric approach, a greater sense of patient empowerment. And although this elegant lady in Chinese attire suggests that that they might work on special populations, we also have studies going on in inner city Baltimore and with people for whom this is a cultural stretch. But it may be for the individual cultural environment that other forms of physical movement that is controlled, that is structured, that is ritualized, including dancing forms that grow out of people's own culture, may be the way that we need to work. But this is, to me, an exciting part of the research. One of the things that's happening right now for us is a very strong interest in the Department of Veterans Affairs and the Department of Defense on complementary approaches for pain management. And here is one of our investigators working with a deployed soldier studying the impact of meditation on his EMG. But acupuncture is also being extensively deployed in military settings, particularly in the Department of Defense. And the evidence suggests that compared to usual care, the effects are pretty strong. If you compare it to a sham acupuncture in which the same ritual is employed and pressure points just off the meridians are used, the effect is much smaller. So I think there's no doubt that acupuncture works in part by the expectancy and reassurance of this ritual. There does seem to be a specific effect that is being studied with the same kind of neuroimaging methods that Dr. Darvari talked about. But this is an ongoing topic of research right now. I have a few slides on an important issue for us, which is safety of dietary supplements, because this is also part of our responsibility. There are a number of dietary supplements that are extensively marketed. The three categories are weight loss, sexual health, and muscle building that are, we frequently associated with contamination or adulteration. At the NIH, we're not the regulatory part of the federal government, but we work closely with the FDA and share the warnings they develop. And so as an example of a dietary supplement that's being widely marketed right now for weight loss, one of them is acai. Some of the preparations of acai have been found to be contaminated with stimulants or diuretics. And in fact, one person even suggested that putting it into vodka was a good idea, and I really don't think it is. And this is an FTC warning about bogus weight loss benefits of acai, and our own website on that material. So complementary approaches are particularly valuable or worth research, and we are focusing a lot of our research dollars on situations where conventional medicine doesn't have all the answers. Here are a few of them. And I've talked today mostly about pain, but complementary approaches may be helpful for sleep, and in fact, herbal tea may be better for an upper respiratory infection than an Z-Pak antibiotic prescription. It is clear that sleep aids are overused in our society, particularly for the elderly. I put this slide up because I'd like to see more research proposals coming in on benzodiazepine use in the elderly, which I think is particularly problematic. This shows the rates of benzodiazepine use by age, and the graph x-axis goes from age of 18 to 80, but the y-axis tells us that women, over 10% of women in their 70s and 80s are being prescribed benzodiazepines. These are drugs that markedly impair short-term memory and are not, the evidence-based guidelines by the American Geriatric Society does not recommend the use of benzodiazepines in this age range, but they are widely prescribed. These are three of the natural products, lemon balm, melatonin, valerian, that may also help as sleep aids. I suspect they are less efficacious than the benzodiazepine, but at least it's a good hypothesis that they have a safer side effect profile. So that's an encouragement or a topic I'd love to see explored. So this is to end with an evidence-based guideline. This is the guideline from the Office of the Army Surgeon General about pain management, and it gives a prominent discussion to the role of complementary approaches to pain management. The evidence, as I've said, is very far from complete, but I think there's good reason to think these are promising approaches. So thank you for including me in a terrific symposium, and I welcome any questions.
Can you speak to the use of, if you're finding anything with the use of vitamin E in chronic pain? That seems to be.
Yeah. So vitamin E is an agent which has a broad anti-inflammatory profile. And so its potential use for inflammatory pain conditions, and that doesn't just include a red-hot knee, it can include inflammation, can certainly exacerbate pain in a lot of conditions. We have talked about more work on anti-inflammatory natural products, including vitamin E, for pain. One of the worrisome things about vitamin E, however, has been data suggesting small increases in colon cancer risk. So we've been talked about this as a potential topic, but we are not currently supporting work on it.
Question.
Yeah.
Thank you for a very nice talk. I've always been intrigued about the relationship between belief, a person's belief, and the efficacy of the approach. And intrigued with the alternative medicine, but I would ask first if the data support that you do see ethnicity or culture correlating with the different types of alternative approaches. And if in that regard, there's opportunity to design studies to really try to get a metric about this.
It's a totally great question, and I certainly think that your instinct that belief is a component. The effect of the subject's belief. I got interested in this whole topic because at the time I began to think about this, I was heading the kidney division in NIDDK, and I was very struck in all the studies we were funding where we had anything they could call even modestly subjective outcome, including a lot of urologic disorders, pain from kidney stones, pain from polycystic kidney disease, how how large the placebo effects were, and how much the expectation of the patient, therefore, seemed to influence the response. I think we have too little work going on right now that really explores the way to utilize this productively. I'm personally, as a doc, not totally comfortable with prescribing placebos. I never did that, because it seems to me to have an element of deception. But I do think that good physicians, good healthcare providers know how to provide that kind of context and reassurance. So some of that may be a provider who comes from the same cultural background as the patient may be better at doing that. But there may be ways in which the availability of, say, meditative approaches or exercise forms that are, in fact, culturally specific may really augment their effectiveness. So I love the question. I don't have a complete answer. Yes?
I've worked with sickle cell for almost 50 years.
Mm-hmm.
And as a nurse practitioner at Children's, one of the things I've found is that you need the young people, the patients, need some type of consistency in individuals who's caring for them.
Mm-hmm.
There's nothing like to induce the anxiety. Every time you hurt, you're seeing a different person.
Mm-hmm.
And the medical setup we have nowadays, I don't know whether you want to say it's good or bad, but it gets away from focusing on the psychosocial aspect of the patient.
Absolutely.
So if there's some way that the medical community and the psychosocial communities
Can get closer together?
indeed
Yeah.
and work on something. So if patients are ill or saying they have pain, there's somewhere, someone who consistently will see the patients, even if it's for a few minutes. Let me just give you an example of something I had. I worked at Children's, and I was always called whenever there was a patient in an emergency. And I was in the hospital visiting 2 o'clock in the morning. Once I was called, the patient was being treated for Czech syndrome. This was the diagnosis that I was told. And had been sent to the emergency room and given medication. When she got back, I examined her. You know what was wrong with her? Breast development. And the problem, this becomes a problem because there's so many things that could enter into the diagnosis of coming to a conclusion with diagnosis. And it concerns me because even though I'm not working in the medical facility right now, I do have contact with lots of families and patients, and I get lots of calls. They're most frustrated that there's no consistency in care, and they get the feeling nobody cares. So something's got to be worked out so that the psychosocial, medical, everybody can get together and let's get the patient on the top line so they can feel that they're getting care. And that would actually reduce a lot of hospitalizations.
I think you've said it so well, I'm not going to try to add it.
I'm so appreciative of your being here, and I'm very appreciative of the prior questions that were asked as they relate a lot to bridging the gap between your talking, say, Dr. Gabari's research, and looking at the anti-nociceptive receptors within the brain that are responsible to like humanistic things, psychosocial, as well as meditative and their effects rather than having it be quote unquote placebo effect. We really made, how to measure that, and that belief ties into all of that. So I think that that type of research would be amazing to be able to show evidence so that we can, as Dr. Wright said, debunk some of the myths and have the things that are not so as much as people would establish.
No, I think we have myths going in both directions. We have providers who, rather than spend time exploring what is really important to the patient and what the pain is really interfering with and what the goals of the patient are in pain management, writing a prescription is the easy way. And at the same time, we have fear of underuse of these incredibly important drugs. So we are seeing both sets of problems. Yeah.
I just wanted to mention, I'm not an expert on complementary medicine, but we were trying to do a study of acupuncture. And the first step is to ask our patients what they were doing already in terms of complementary medicine. It turned out the number one thing they were doing, at least the way we define complementary medicine, was prayer. Many of our patients, that's a very essential element in how they approach their painful crises and other episodes. And it's amazing that, it's absolutely not visible when we deal with people on a day-to-day basis.
No, that's an important observation. Because prayer is quite ubiquitous, people who pray, for whom prayer is a central part of their lives, will, I think, essentially all turn to prayer faced with serious life challenges. So we have felt that to include that in a list of complementary health practices was a little misleading. It's almost like the question becomes, are you somebody who incorporates prayer into your life? And if so, if you have a health problem, do you pray about it? As opposed to, are you utilizing a dietary supplement? So it's felt like two different things. So, but the role of religious beliefs and cultural beliefs, and the role of prayer, which is in many ways, in many cultures, also a meditative practice, it is very important. Yes?
I understand let's look back here. I'm going to ask you about the use of potassium as a with people having dementia. I'm 86 years old. I need to speak up to look at the chairs out. Until recently, I had not been in medicine for almost 40 years. But they used to use them in South Carolina as regular medicine. They made for themselves. They did whatever they had planted out of the I've been taking now for maybe 20 years potassium and what's called hormone resistance. It's harder to be like it. Just recently I found, and they ended up giving me back to capillary bleeding, bleeding in the heart and my liver.
So I think the clarity with which you speak illustrates that you've got a pretty good regimen that has allowed you to maintain health, because you certainly don't speak with the rigor of someone much younger. My own reading of this literature, it places potassium as part of what a high fruit and vegetable diet does for us. And potassium is quite abundant in most fruits and vegetables. And a diet in which the potassium and sodium ratio is favorable will, in general, tend to result in lower blood pressure and in less of the vascular problems. And indeed, we're increasingly realizing that high blood pressure contributes to the dementia of old age.
So,
You know, whether you need B vitamins probably very much depends on your diet, but B vitamins do seem to be quite safe.